Okay, I'll keep using this. We apparently should not use Hans Hinselmann's name anymore because he, even though he did introduce colposcopy, he was subsequently found to have abused his medical circumstances whilst developing colposcopic material in concentration camps in Germany. And the UK Colposcopy Society and the German Colposcopy Society no longer refer to Hans Hinselmann, rather that colposcopy was developed in Hamburg in the early 20s in collaboration with a medical manufacturer. It was developed subsequently by Adolf Staffel in the US, Joe Jordan in the UK, René Cartier in Paris, and many others. But what is it? It is simply, very simply, light-illuminated, low-powered, microscopic examination of the in vivo cervical epithelium and underlying stroma. And it may or may not have a camera attached. It can recognize precancerous and cancerous disease. It can recognize infection and hormonal changes, menstrual cycle changes, atrophy and pregnancy changes. It can recognize a number of other benign conditions. How good it is at doing those things, we can discuss over the next few days. And where its real role is, we will be discussing in detail. As I say, it's used in different circumstances in different countries. In some countries, it's used as the primary screening tool, though the evidence would suggest that it's not very good at that. In most places, it's used to investigate women with an abnormal smear or a suspicious symptom or sign. And it's used, in most countries, it's used to facilitate precise treatment. I think that's a very important point that we'll come back to later. Treatment really should not happen if it's excisional without colposcopic control. Its traditional role has been in discriminating between the grades of CIN, and its main use today at a diagnostic level is to discriminate between mild abnormality and to confirm precancer and facilitate precise treatment. Okay, we're going to come back to that later. So if you're establishing a clinic, what do you need to buy? In Ireland, as you know, we have a financial crisis. We made the stupid mistake of changing a bank debt to a sovereign debt, and we're now in serious recession. And so if we were establishing a colposcopy clinic tomorrow, we wouldn't get anything from our hospital administrators. They would laugh at us, and our purchasing power in the health sector has disappeared. But when we established the colposcopy clinics in Ireland about 10 years ago, 15 years ago, as part of the beginnings of our screening program, we did have power to purchase. And so what I'm going to tell you about equipment is based on what we bought and what we use in our circumstance. And the first thing I think you need for a clinic is a meet and greet room, so the patient doesn't come straight into a colposcopy couch, doesn't come into a cold, empty, bare room, but comes into a room that is welcoming. She then is interviewed by secretarial staff to get her sociodemographic details in private, and her cytology or smear report or whatever she's had done is documented. There should be a room for the nursing and admin staff, and there should be a room for the doctors. There should be a comfortable private waiting room. It's nice if there's tea, coffee, radio, and other information. The most important thing you should have in your clinic is the lady in blue. If in your colposcopy clinic you don't have a professional, sympathetic, empathetic, informed nurse, then you can forget colposcopy. You're just going to have a fight with your patients, and you're just not going to manage to do what you want to do in the outpatients. The so-called vocal local that a reassuring nurse can give to your patient is hugely important. It's very hard to teach attitudes to gynecologists, male or female. But if the patient has a trusting advocate in the room, as well as an empathetic doctor, then you really can do almost anything to that patient that you need to do. In the colposcopy room, first of all, and this is something we insist on, and I have been disappointed to see in many, many parts of the world, that when the woman is in the colposcopy room and in the colposcopy chair, the door is not locked. The door needs to be locked. So the first bit of equipment you need is a door with a key, so that the patient knows that when she's in the couch, the door is locked and nobody else can walk in on her. And I think all of us should take off our lower half of our clothes and sit in the colposcopy couch and realize the indignity and the vulnerability of sitting in a colposcopy chair before we ever ask anybody else to do it. Because it's incredibly intimidating. Not many men get to do that until they get to my age and they get prostate disease. And then they have to suffer the indignity of seeing a urologist. But women have to do it throughout their reproductive life. And it's very hard to appreciate the vulnerability of that without sitting on the couch yourself. They need a changing area that should be private, a wash hand basin, 2 of them, one for the doctor, one for the patient. A storage facility for all the equipment that you need for an individual examination. So you should never have to leave the room to get a piece of gear, because that means opening the door. Chairs, desktops, computers. A colposcopy trolley will allow you to house everything that you need for your examination. Your disposables, your reusables, your fluids, your instruments. An examination couch, obviously, an examination stool, a video stack, an electrosurgical unit, a suction unit, and a data and image capture system, if you can afford that. So, this is the Bristol-made trolley, and I'll just show you the side of it here, which is where you put the Lugol's iodine and the acetic acid. In fact, they look like they're both Lugol's iodine bottles. I apologize. Not everybody likes to use a spray bottle. I know some of my colleagues say that a spray bottle risks the fluid bouncing back and touching the examiner's eyes or face. I wear glasses, so I don't see that as an issue, and I think you can spray on fluid very lightly. It does have the advantage of meaning that it's non-touch. You're not touching the cervix with a swab initially, and you can put quite a lot of fluid on. You always subsequently do touch the cervix to remove mucus with a cotton tip bud or with a swab. But I think the spray is a nice way of originally soaking the cervix with either saline, acetic acid, or iodine. On the tray, I have very few instruments on top of the tray. I have jumbo swabs to the right. See if this laser pointer works, it does. I have these jumbo swabs to the right, and then small cotton tip buds as well. I have a cotton wool ball with a sponge forceps. This I sometimes use for deflecting the vaginal fornices to allow you to examine the cervix. A regular Cusco speculum with a suction tube on it, a dental syringe, and I use Cytonest with octopressin, and they're just cork. I think they're just cork, yes, oh no, that's Moncels. That's Moncels paste, and then some sponge, cotton wool swabs. In the bottom drawer, we have a selection of gloves. In the middle drawer, we have 3 different speculae sizes: small, medium, and large. And of course, if you're examining a nulliparous patient, you need a small one, a parous patient, a medium-sized one, and a grand multiparous patient, a large one. And that, of course, isn't an absolute rule, and you need long and short versions of each of those. I think it is what we call a mortal sin, or a serious offense, to put the wrong speculum into a woman. If you don't have a variety of speculae, you will put the wrong speculum into a woman at some stage in your clinic. At the top drawer, we have some gel, hibitane, cork boards for pinning specimens, pins, needles for the dental syringe. I can't see what they are. I think they're culture swabs, and then cotton tip buds. And they're brush samples. UK doesn't tend to do endocervical curettage. This is a difference between North America and much of Europe. Though some European countries do, the UK and Ireland don't tend to do endocervical curettage. They use endocervical brush cytology. They would use hysteroscopy, transvaginal scanning, to assess the endometrial and endocervical canal, but they don't tend to do curettage because they feel it's painful and doesn't add any information. So that's a difference between North America and the UK. The colposcope that I use is a Zeiss colposcope. I've had this Zeiss colposcope for 25 years, and it's still got very perfect optics. It allows me to attach a digital camera. It's a very easy replaceable light source. It has a number of magnifications starting at 4 and going up to about 15. They easily change from one to the other, and it's relatively easy to switch from one magnification to another, and I always adjust the two eyepieces at the beginning of the clinic to suit my eyes, and you need to do that every time so that you get the correct focal length. The focal length of this is 30 centimeters, and I think that's very important. If the focal length is more than 30 centimeters, you're sometimes too far from the speculum and the vulva and the cervix. If it's too short, you can't get instruments between the colposcope and the speculum comfortably. So 300 millimeters or 30 centimeters is about the right focal length. This is an electrically operated couch, and I think that's maybe considered a luxury, but I think it's very important, such that the table can be lifted up or down so that the operator isn't bunched over or stretching. It can be tilted, the back can be tilted, and the base can be tilted. And it can also go completely flat. The colposcope, I believe, should be binocular. In a lot of parts of the world, they're selling uniocular, Welsh Allen uniocular video scopes that don't allow you to look at the cervix directly. You have to look at the screen, and there's nothing wrong with looking at the screen. But if you just look at the screen, you don't get, without a binocular view, you don't get an appreciation of depth of field. And it's more difficult to determine the depth of your excision when you're treating the patient. The colposcope should be ergonomically sound, such that it's easy to rotate it and move it in and out. It should have several magnifications, obviously high enough to visualize blood vessel abnormalities, but I also think it's important that the colposcope has a low enough magnification whereby when you're treating somebody, you can see the entire cervix and the vaginal walls and the entire loop that you're using, so that you're not going to lose view of the loop as you're passing it, whereby you could hit the vaginal wall, or you could end up in the bladder or the rectum or a vaginal wall vessel, and I've seen that happen. It should have a beam splitter and a C-mount, and they're expensive to allow you to put on a teaching attachment, and that's usually a video, and it may be floor mounted or couch mounted. This is a view of mine on higher power. They're very simple machines. They're ridiculously expensive for what they are, And I think the newer colposcopes are going to be much cheaper with LEDs. They're going to be much lighter. They're not going to require the same mounting arm that is so heavy and expensive. The couch needs to be electrically driven. It needs to have 3 motors to allow independent movement. I've already said that. It needs to be comfortable. And it needs to be able to go flat quickly. Because very occasionally, particularly if you use lignocaine and adrenaline, very occasionally you'll get a vasovagal reaction. Now, I don't use lignocaine and adrenaline. I use usefulness with octopressin, which is what you'll probably find your dentist uses. And you just don't get vasovagal reactions. You don't get any shaking, and you don't get any cardiovascular risk. So if you can get usefulness with octopressin, it's safer. Cusco speculum, I already mentioned, small, medium, large, long and regular, and there should be suction tube on nearly all of them. A local anesthetic system, I use a dental syringe system with 2.2 ml vials, and they're available for lignocaine or usefulness. Sponge holders, endocervical forceps, biopsy forceps. Now, I don't think that this is necessary, but I personally don't use biopsy forceps very often. I tend to use a small loop. So if I'm going to take a biopsy from somebody, I use a very small loop on pure cutting rather than a punch biopsy forceps. It's cheaper. I think you get a better specimen. But I think for most people, especially when you're starting out, I think a regular punch biopsy forceps or a titular forceps, for example. Diathermy loops and balls for treatment, and I already mentioned cotton tip buds and swabs. So there's the regular Cusco speculum that we use. More and more clinics I see now are using disposable speculae for everything. I personally don't like them. I don't think they're as good at exposing the cervix comfortably, but I think that's the way it's going. Endocervical forceps, whether it's a Desjardins forceps or a Curry-Harry forceps or a Cogan's forceps, are all means of gently opening the cervix to allow you to examine the endocervical canal as far as you can reasonably and comfortably do. On my trolley, in my own private practice, I tend to put these instruments in something like this, so that all the loops and all the balls are all available, cotton tip buds, and are very easily accessible, and that's just personal preference. The loops that you can buy on these, I have no shares in Megadyne. They're cheaper than Utah, who first made my loops, but you can see that the sizes, there are as many sizes as there are transformation zones. And these are the ones I use for taking biopsies. That's about 5 millimeters across. Sorry, about 2 millimeters across, the purple one. Ball diathermy can be small or large. Mediscan, there are about 4 different data management and image capture computer systems. There are 2 that we use in Ireland. Mediscan is the more popular one. They, again, are very ridiculously expensive for what they are, but they allow you to put in the socio-demographic details, the secretary puts them in, the clinical details you can put in, and the image that you see, you can video record and store, and then you can put the histology images in if you want as well. You can also use it for hysteroscopy, and indeed if you've got one in theatre for laparoscopy. But it's a very good way of following a patient. So you can look at her original smear, you can see the original biopsy, you can see the original colposcopic examination a year later when she comes back, whether or not you have treated her. This is the clinic scenario in my hospital that I worked in for many years. That's another view of it, and that's another view of it. The fluids you need, I've already mentioned saline acetic acid. In fact, Jim quite rightly gave you choices of 1, 5, or 50% acetic acid. In fact, a lot of clinics use 3%, particularly in the UK. And I don't think it matters which you use, 3 or 5%, but don't change. Keep using the same concentration because the uptake is slightly different. Lugol's iodine, KY jelly, I've mentioned those other. Okay, I'm going to talk about that later. I'm not going to do that now because time's run out. This finally is an example of what you all want to see, which is a nice normal cervix in optimal hormonal circumstance, mid-cycle, nice, clear, non-infected, transparent mucus, allowing you a vision of the endocervical canal, of the transformation zone going from here to here, nice normal endocervical canal, nice normal squamous epithelium outside the transformation zone, and no suspicion of disease. Actually, I'm going to skip that because the British Society would now like to formally invite all of you to come to the International Federation for Cervical Pathology and Colposcopy in London later this year, where, as you can see already, there are blue skies just waiting for you. The Queen Elizabeth II Conference Centre is smack in the middle of London, next to the Houses of Parliament and Big Ben. It's smack in the middle of London, on the River Thames. It is a really, really good conference venue, and it's close by to lots of entertainment, shopping, and cultural activities. A number of courses will be held in parallel to the conference, both in epidemiology, biology, cytology. And this conference, which is held every 3 years, is the pinnacle of our endeavours in the IFCPC. I'll talk to you later about the IFCPC, but I really do hope that you will take the time to visit London and attend the conference in May 2014. Thank you for your attention.